Hello, everyone. I'm Muriel Finkel, and on behalf of the Amyloidosis Support Groups, I welcome you to our webinar for our AL patients and loved ones. Our previous webinars can be seen on our website. Click on the webinar link and on our YouTube channel. And this one should be up in about 2 weeks, okay? We're very cautiously, slowly dipping our toes in the water to start our live meetings. So our first one's going to be in Phoenix next week, and we hope to start a few more next year. So gradually, as the hospitals allow us to meet, and as the doctors and the centers reach out to us, we are cautiously and slowly restarting the meetings. Meanwhile, for patient-to-patient contact, the best way to do that is joining our Facebook groups. They're all private and closed, excuse me. And there are questions that must be answered before you join. So they're really good groups. During today's webinar, you won't be able to post comments in the chat or ask questions in the Q&A. We'll be addressing the questions that were emailed in. There were so many of them, we probably won't get even to all of them today, but we are asking our wonderful physicians to respond to all of them, and then we can email you back the responses that we don't get to today on the webinar. Some questions were very personal nature, and they weren't necessarily of general interest, but we know that you want a response, and we'll try and get one for everyone. So just be patient and wait for that, okay? Meanwhile, there will be some things posted in the chat by Paula. So Paula, our executive director, can you say hi?
Good morning, everyone. Thank you for attending today.
Okay, and also in the booth, as always, thank heavens, right? Our security blanket is Bob, our special projects director, Bob Gibson.
Good morning. I hope it's a great webinar today. We've got a great group.
Okay, and on our esteemed panel today, and we do thank them for giving us their Saturday. It's a beautiful Saturday here in the Midwest, so it's probably beautiful where you are as well. So here we have our wonderful amyloidologists, and they include Dr. Morie Gertz from the Mayo Clinic in Rochester, Minnesota. And then we have Dr. Anita D'Souza from Froedtert and the Medical College of Wisconsin, and Dr. Nelson Leung from the Mayo Clinic, and Dr. Ashish Verma from Boston University's Amyloidosis Clinic. We're breaking him in now, right? And then we have Dr. Tony Urey from UCSD. I don't know if he's awake yet, but kind of early out in the Pacific. We have with us our cancer rights attorney, Monica Fawzi Bryant, Esquire. She's our insurance and Medicare expert. And from Columbia University, we have Dr. Cara Rosenbaum from Weill, Cornell. Oh, and did I leave off Dr. Rochester Chakraborty? I'm sorry, he's from Columbia. I'm out of order here, folks. Okay, we haven't done one of these in a long time. Okay, and joining us in our pharma world is Spencer Guthrie from Atralis, and Ansgar Conrad from Prothena. And then we have from Alexion, Julia Catini. Okay, there's going to be a quick survey at the end of the program, and we do ask that all of you fill it out. It's really important for us to figure out what it is that you're looking for, what you'd like to see on future webinars. So we ask that you please take the time to fill them out. If you have to leave early, then fill it out then too, okay? We'll be working off our treatment chart today. Bob, can you show everyone what the chart looks like? Thank you. And you don't have to worry, we're going to put a link up for that, but that way you don't have to worry about how to spell certain drugs or what are they. And we'll share that link, or you can feel free to email me at muriel@amyloidosissupport.org, and we'll get the link to you. We want to thank Dr. Jeff Sonder from Carmenos for updating this chart for us, as he's been doing every year for quite a few years. Okay, so we're now going to hear from our #1 amyloidologist. Okay, I say that Dr. Gertz was one of the first doctors to support us back in 2004, and we are forever grateful. So Dr. Gertz, take it away.
Thank you very much. I'm going to spend the 24 minutes that I have primarily discussing you managing the side effects of the medications that you're going to hear about throughout the day. And I'm going to start with everyone's favorite, dexamethasone. Dexamethasone is uniformly used in virtually every treatment regimen for amyloidosis because dexamethasone has the ability to kill the plasma cells in the bone marrow that are the source of the amyloid light chains that are responsible for leading to organ damage of amyloid. The link to the Karmanos Cancer Institute therapy page will be very useful as I go through my talk, and definite thanks to Professor Zonder for producing this because this is going to be referred to all during the day. So if you have access to that link, I'd click it and have it available to you. So I'm going to start with dexamethasone. Why dexamethasone? Well, we did a study, it's probably 30 years ago, using dexamethasone alone in the treatment of amyloidosis, just by itself with nothing else. And we found that it was clearly capable of producing both responses in the amyloid protein reduction as well as organ healing. So Decadron is highly effective for the treatment of amyloid, and it's better if you combine it with other medications. But those of you who've taken Decadron realize it is a very difficult therapy to tolerate. So those of you who take it recognize that the night of your treatment, you're not going to go to sleep. You're going to be up at 3 to 4 a.m. in the morning doing whatever people do at 3 or 4 a.m. in the morning. And they're going to suffer really quite severe mood swings where they're going to be up. And then once the Decadron, which is given only 1 day a week, followed by a couple of days of withdrawal where you're feeling down and you're feeling unwell. And in some patients, it'll cause explosive increases in blood pressure. For people who are predisposed to have blood sugar issues, it can actually take a pre-diabetic and put them into full-blown diabetes. In addition, people who take dexamethasone or Decadron have a higher risk of developing serious infections. And in some people, it can cause cosmetic changes because it can cause a real voracious appetite. It really makes you hungry, and it's very hard to maintain a stable weight when you're taking dexamethasone. So I want to step back and talk about the evolution of dexamethasone and how we might be able to manage some of these side effects. These mood side effects may not even be apparent to a patient. It's very common to see patients in the office and ask the patient if they're having any side effects from their dexamethasone, which is in column 4 of the Karmanos Cancer Institute therapy for amyloid, and have them answer no, no side effects, and then have their significant other or partner roll their eyes, make faces at about, what are you talking about? No side effects. I mean, the drug is causing you terrible, terrible problems. Inexperienced physicians will often treat patients with doses of dexamethasone of 10 tablets once a week. And that 10 tablets once a week comes from the results of treatments in multiple myeloma, a pretty closely connected disorder where the standard was 10 tablets once a week. So how did we get there with 10 tablets once a week? Well, to be honest, it was done in a very unscientific fashion in the very late 70s by Dr. Barthel Barloghi, who ran the Myeloma Center at the University of Arkansas. today, dosing of medication is done in a really scientific fashion where patients participating in trials are given relatively small doses, and then the dose is slowly increased until side effects develop. That is not how dexamethasone was developed. The dose was really quite selected as basically a personal preference of Dr. Barloghi, and it caught on and became the standard of care for patients. In fact, when dexamethasone was first introduced, it was actually given not once a week, but it was given 4 days on, 4 days off, 4 days on, 4 days off, 4 days on, for a total of 12 doses every 28 days, as opposed to the way we use it today, where it's weekly or 4 days a month. And in those days, we saw really terrible complications with it. We saw people hospitalized with psychiatric problems due to extreme changes in mood, manic would occur. People who would require medication because they would develop very, very vivid and intolerable dreams. People hospitalized because their blood sugar would be 5 to 10 times normal. And it was subsequently demonstrated you could get by with once a week, but even so, the dose of 10 tablets once a week was excessive and still caused patients terrible distress. So what's to be done about it? There are patients that we've seen who actually develop bowel perforations from the high doses of dexamethasone, and they'd start treatment. Usually today it would be daratumumab, cyclophosphamide, bortezomib, dexamethasone, Daracibor-D in the lower left-hand corner of the Karmanos chart. And those patients would be hospitalized for weeks due to perforation, and occasional patients would end up with a colostomy that would be present for months before it could be repaired related to dexamethasone. In addition, there are reports of very severe heart complications in patients with severe heart amyloid when they're given dexamethasone. And also patients who have significant kidney amyloid, where they spill lots of protein in the urine. The dexamethasone can cause profound fluid retention. People will gain 5, 10, 15, 20 pounds in body weight when they start dexamethasone. And this can cause hospitalization and can cause serious problems. So if you've taken dexamethasone and you've had serious problems, you're not alone. It's clearly the most toxic medication in the amyloid armamentarium, which is used with virtually every regimen, every common first-line regimen that we have. So what's to be done about it? What's the discussion to be had with your provider? Because you really don't have to just sit and take it. You don't have to accept these side effects. There is no data, there's no scientific information to say that 10 pills a week is required. And most of the people that you'll be hearing from today would probably agree that for the majority of patients, it's safe to start at 5 tablets a week without compromising outcomes. And in my practice, quite honestly, when it comes to using dexamethasone, it's pretty typical to use 3 tablets a week in patients who have significant heart or kidney until you can find out what's tolerable. And I find it better to start lower, work my way up, rather than start high and have people have terrible side effects, start talking about quitting treatment, and then having to lower it. So 3 tablets a week. I learned from Dr. Ashu Wakelekar, who leads the Amyloidosis Center in London, that it's quite common in his practice to substitute a less toxic steroid, prednisone, or intravenous methylprednisolone for dexamethasone. And I agree, this is much easier. I would note in the Karmanos chart where you see steroids, it's important to understand that the steroids that we're referring to are scientifically, we call corticosteroids, and we should distinguish this from anabolic steroids that competitive athletes often use to improve their performance. So these types of steroids aren't going to deepen your voice or make you grow a beard. These are corticosteroids, so just not to be confused that way. Well, Dr. Weill, what he's gone to do in patients who have significant side effects, or he's concerned about fluid retention with heart or kidney amyloid, is he drops out the dexamethasone and uses either oral prednisone at a relatively high dose for 3 or 4 days, or alternative to the weekly dexamethasone, will give an intravenous dose of methylprednisolone. And these medications actually have a much shorter half-life than dexamethasone. And so the side effect profile is much lower and it's much better tolerated by patients who are receiving steroids as part of their treatment. So it's really important for those of you who are suffering significant side effects from dexamethasone to recognize that there are alternatives and options to discuss, and that there's no rule that locks you into 10 pills once a week. I want to turn my attention next to the side effects of bortezomib. Bortezomib, which the trade name is Velcade, is probably the backbone over the last 15 years for the treatment of AL amyloidosis. It currently is given as an under-the-skin injection, and it's given once a week. And its side effects include diarrhea, that's pretty common, and getting some redness at the injection site is common, and it will lower the blood count, particularly the platelet count. So you'll find in practice that it's not unusual for your provider to monitor your blood count once a week, once a month, to be sure that the medicine itself, the injections of the bortezomib, the Velcade, aren't causing bad effects. But that isn't what I want to focus on. What I really want to focus on is the ability of bortezomib to damage the nerves. Bortezomib can be quite toxic to the nerves, and if it's not monitored closely, can result in irreversible, quite symptomatic nerve damage that you need to be aware of and guard against. You have to be your own advocate on this. What bortezomib does initially in some patients is it begins by causing numbness in the toes, and that numbness will spread to the soles of the feet. And if it's continued without dose modification or interruption or changing the frequency in dosing, that numbness will begin to ascend up your legs to the ankle bones, bottom of the calf, middle of the shin, all the way up to the knees if it's not taken care of. This can cause serious problems. People describe to me it's like they're walking with thick woolen socks, or they're walking on thick pile carpeting. And as this progresses, it becomes progressively difficult to recognize where your feet are. And so people all of a sudden start to develop fall risk because they're not quite sure where they're placing their feet. And as the numbness continues, it starts to interfere with the activities of daily living, such as the ability to drive a car, because you're not able to tell how hard you're pushing down on the gas pedal, and worse, you're not able to tell how you're pushing down on the brake pedal. And so you lose sensation, and those can be really challenging problems, but still isn't the most serious problem associated, because the bortezomib can damage the small fibers, the small wires in your feet that mediate the sensation of pain. And if it's not taken care of, these small fibers can develop damage that results in really quite severe pain in the toes, in the feet, and up the leg that most patients will describe as stinging or burning. And as it progresses, it starts to interfere with your ability to sleep. And then pretty soon you start having jolts and lightning in your feet that begin to last all day. And a not insignificant number of patients who have received bortezomib can develop long-standing painful damage to the nerves, causing burning in the feet. And then these patients end up requiring indefinite supplemental medications such as gabapentin, which is used to reduce the pain, or pregabalin. The trade name for pregabalin is Lyrica, to maintain the pain. Many people start to need sleeping medications in order to fall asleep. And a lot of people start to require strong pain medications, up to and including opioid medications such as oxycodone or Oxycontin, to control the severity of the pain. And the best way to prevent this complication from occurring is to interrupt, dose reduce, or reduce the frequency of bortezomib administration at the first sign of numbness. And you have to be vigilant about the potential for developing this nerve damage in your feet. Why does it occur? Well, part of the problem is that in a general hematology or oncology practice, the oncology nurses who are administering the medicines and are used to monitoring for side effects focus on a lot of the blood tests. So they are very good at watching for low blood counts, changes in liver function, changes in kidney function that call for dosing modification. But it becomes a very separate issue when you start quizzing patients for side effects such as numbness in feet and burning feet, because this is a problem that only occurs in a small fraction of the general oncology population. And so quizzing patients is often overlooked about burning or numbness. In addition, inexperienced oncologists who don't use a lot of bortezomib or Velcade will hear from a patient that they're starting to develop mild numbness in the feet, and the response often is, oh, that doesn't really sound too bad. I think that's not really enough to make a change, a little bit of numbness, and we'll keep going. That's generally a judgmental error, because if you don't act at the first sign of the sensory loss, the numbness, it can rapidly become a real problem. And so experienced amyloidologists, including everybody that you'll hear from today, know that at the first sign of numbness, they're starting to make serious modifications in the dosing, because it is a real issue with regard to long-term quality of life that can be really quite disruptive, even though it's superb in producing responses in the amyloidosis, both the light chain levels and organ responses. So a lot of caution to all of you that are receiving bortezomib to keep an eye on the numbness, or particularly if pain, to demand that modifications be made. I'm going to use my last 5 minutes to talk about side effects of cyclophosphamide. Cyclophosphamide is a 60-year-old medication used in the treatment of both multiple myeloma and amyloidosis. It's a truly highly effective treatment. It can be given orally, and I'd say most people get it orally as part of the Dara-Cybor-D. It's the CY of Cybor, cyclophosphamide or Cytoxan. Most people will take it once a week as pills, 6 to 10 pills once a week, with the dose modified based on the blood counts. But some people get pretty significant nausea as well as vomiting with the weekly administration. And so some providers will give it as an intravenous dose, same level. That tends to actually reduce the severity of the nausea and vomiting. But the things that we watch for with cyclophosphamide are reductions in the blood counts that could possibly trigger the need for transfusional support, lowering of the white blood cell count that can require dose modification, or the co-administration of a growth factor to help stimulate white cell production to reduce the risk of infection, which is the consequence of a reduced white blood cell count. In some patients, they'll see some degree of thinning of scalp hair, although at the doses that are administered, significant severe hair loss uncommon, but some people do have sufficient hair loss that it becomes a cosmetic issue. Finally, I want to talk about the side effects of daratumumab. Daratumumab, the only approved medication for the treatment of AL amyloidosis by the FDA. It really is a highly active regimen, and I think almost all amyloidologists use it in the United States, first-line therapy for patients with amyloid because of its very high effectiveness. But a couple things. It is really quite suppressive to all of the plasma cells. So it suppresses the amyloid light chain production, but it also suppresses all of the immunoglobulins, G, A, and M, the blood immunoglobulin proteins that help fight off infection. And as a consequence, people who get daratumumab or Darzalex, usually given as a weekly subcutaneous injection, have a significant increased risk of infection related to the suppression of those immunoglobulins. In addition, because it suppresses plasma cells and immunoglobulin production, those are the cells that are responsible for vaccine responsiveness. So people who are receiving daratumumab have a blunted response to the administration of all vaccines, including the COVID vaccine and the influenza vaccine. That doesn't mean we're not going to use the daratumumab or the Darzalex, but you need to be aware that the use of the medication can increase the risk of not only upper respiratory infections, but may reduce the degree of immunity that you have with regard to the ability to fight off COVID and influenza. I'm only going to mention one more side effect before I yield the floor. Professor Liedtke was going to talk about Revlimid and pomalidomide, which are, you'll find in column 5 in your therapy for amyloid. Their trade name, their generic names are lenalidomide and pomalidomide. I want to talk about the risk of blood clots. There's a significant risk of blood clots, and with long-term use, nearly 10 to 15% of patients will eventually develop a blood clot if they're on Revlimid Pomalyst, lenalidomide pomalidomide. And so patients on those drugs, by necessity, particularly because they can have heart disease, which in and of itself increases the risk of blood clots, or heavy levels of proteinuria, protein in the urine, which can increase the risk of blood clots. Those patients need to have some type of preventative treatment against the development of blood clots. And that is a matter of opinion, and it's variable from center to center. But no preventative treatment is not an acceptable answer for people who are receiving either Revlimid or Pomalyst. So, Muriel, I know that has nothing to do with what I was supposed to present, but I thought it was too important for this size an audience to not talk about managing the side effects of the highly effective treatments that are currently used for managing patients with amyloid. Very effective, improving response rates and improving survival, but we need to manage those side effects. So I'm going to mute myself now and yield the floor, and I'll see you back in 25 minutes for Q&A.
Thank you very much, Dr. Gertz. I agree with you. That was really valuable and very important, and generated a whole bunch of new questions. You should see my inbox, but I'm not going to look right now. And before we bring on Dr. D'Souza, who's doing a wonderful job substituting for Dr. Leitke today for presentation. I do want to mention that the chart that we're talking about, our treatment chart, if you go into the chat, Paula was nice enough to put the link in there. And if you just click that link on, you'll be able to see all the treatments that Dr. D'Souza is going to be talking about and Dr. Gertz referenced, and we're going to be talking about all day long. So Dr. Anita D'Souza from Frederick and Medical College of Wisconsin, take it away.
Hi, everyone. Hopefully you can see my slides in the right mode, but unfortunately, Dr. Leitke couldn't make it to this session, so I will try to talk for the next 20 minutes on her topic, which was on immunomodulatory drugs, alkylators, and anti-fibril drugs. And we got a few questions from the group on each of these classes of drugs. I want to thank Dr. Gertz for kind of introducing these topics already. He already covered the alkylator, cytoxin, and then the IMiDs, some of their unique toxicities. So what are IMiDs? So IMiD stands for immunomodulatory imide drugs, and there are 3 in this family, starting with the first one that came in the market called as thalidomide, or Thalomid is the trade name. Following that, we got lenalidomide or Revlimid, and then the most recent one is pomalidomide or Pomalyst. All 3 of these drugs are FDA approved in the US to treat multiple myeloma. None of these are FDA approved to treat amyloidosis, but these are still active drugs. They work well in many kinds of plasma cell disorders. So why do we use them? So this is an active class of drugs that can target plasma cell disorders. These are indeed the backbone of nearly all regimens that we use in multiple myeloma. They have synergy with other active drug classes, such as the proteasome inhibitors, that is Velcade, and other drugs such as ixazomib or Ninlaro, and also with monoclonal antibodies. So in myeloma, for example, we use Revlimid or Pomalyst quite frequently with drugs such as Darzalex or isatuximab. And usually, while we give them in combination with other drugs, we can also use these as monotherapy, especially if we are concerned about tolerance when combined with some of these other active drug classes. But we also have to be wary of some unique toxicities of these drugs. So one thing that is nearly universal with IMiDs is that they can cause a paradoxical increase in cardiac biomarkers, so BNP, NT-proBNP, or troponins in nearly all patients who get these drugs, but without necessarily worsening heart failure. So what I'll see in my clinic is that the light chains come down within a month or 2 months of starting a patient on, say, Revlimid or Pomalyst, but even if they are tolerating the drug quite well, they're not feeling more short of breath, their heart failure symptoms are stable, their diuretic dose is stable, their NT-proBNP will have gone up 200-300 points compared to their baseline. And then as we continue the drug over the next few months, it will slowly settle down again. So this is something to be really, the doctor needs to be aware of. Sometimes we need to adjust some medications like the diuretics if we see that along with the increase in the biomarkers, there's also more fluid retention. But in general, if we know about this beforehand, we can counsel our patients, and we can be not. I think the important thing is not to get too excited when you see that cardiac biomarker jump up. Now with thalidomide, sometimes toxicities can be very limiting, and at least in my practice, I've not used this drug in amyloidosis. I think we are fortunate in the US, we have lenalidomide and pomalidomide, but in some other countries, thalidomide is still very much a drug that is commonly used to treat multiple myeloma. More than 50% of patients will have some rough side effect. The main ones to remember are peripheral neuropathy. So just like with Velcade, thalidomide can make neuropathy worse. In amyloidosis in particular, we have seen problems with fluid retention as well as renal disease, so progression of renal failure. in clinical trials that use thalidomide. Those are the reasons why I'm very cautious about using this drug in my amyloidosis patients. Now, lenalidomide, on the other hand, or Revlimid, is little more tolerable, although I do start at a lower starting dose. So the doses of lenalidomide range from 5 to 25 milligram. And in myeloma, while we would start nearly all patients at 25 milligram a day dose, in amyloidosis, I will typically start at a lower dose, either 10 or 15 milligram. And again, as mentioned previously, you can use it as a monotherapy, so lenalidomide combined with some dexamethasone, or it can be combined with either Velcade or alkylators such as Cytoxan, or monoclonal antibodies such as either Darzalex, isatuximab, or elotuzumab. Some of the unique toxicities, Dr. Gertz mentioned the thromboembolism. So all patients should be on aspirin when they start lenalidomide. If they've had a previous history of a blood clot, then we have to up that thromboprophylaxis regimen from aspirin to something like Eliquis or Coumadin or Xarelto. Lenalidomide can cause a skin rash. It's very common in that first month of use. In general, this can be managed by holding the drug for a couple of days and using topical supportive care medicines, such as either corticosteroid cream, such as hydrocortisone or Kenalog ointment, or using drugs such as Benadryl. It can also cause fatigue. So sometimes that fatigue can be a rate limiting factor where we have to cut down on the dose. We also watch blood counts because lenalidomide can lower hemoglobin, white blood cell count, and platelet count. Now, pomalidomide, which is the newest IMiD agent in that class, its toxicity appears to be more manageable than Revlimid. It's given at doses 1 to 4 milligram a day. And I would generally start at 2 milligram unless patients are, we feel they are able to tolerate a higher dose, then we can start at the full 4 milligram dose. I do want to point out interesting and exciting clinical trial. It's an investigator-initiated trial of daratumumab, pomalidomide, dex. And I'm happy to see that Dr. Cara Rosenbaum from Weill Cornell is one of the panelists today. It is a trial that she initiated. It's open at 4 sites in the country, and I'm hoping she'll be able to talk more about it later. But this regimen or this trial allows patients who have previously had daratumumab. So for example, if you've had previous Cara-Cyborty or single agent daratumumab and had a response to it, but say years later, there's now need for a new regimen. At least we've treated a couple of patients and we've seen some really nice responses. And she presented these preliminary data at the recent ISA meeting last month. Now, with the alkylators, Dr. Gertz talked about cyclophosphamide or Cytoxan. There are a couple of other alkylators in this class, starting with melphalan, trade names Alcaran, Evomela. This is the same drug that we use in stem cell transplant. It's given at a much higher dose and given intravenously, but there's also the oral formulation. And in the good old days, Mel-Dex was one of our starting regimens that we used in nearly all patients, either melphalan with dexamethasone or melphalan with prednisone. And Cytoxan similarly can be given orally or intravenously. And in our current upfront therapy, Cytoxan is really a backbone drug with either Cyborty or Dara-Cyborty. And then there is another alkylator called as bendamustine, which I use in the relapse setting. So when we are treating the amyloid disease a second or third time, this can be a useful alternative in some patients. Main things to worry about with side effects of alkylators. So these are the old-fashioned chemotherapy drugs. So they can cause nausea. We often have to be mindful of it and make sure patients have access to anti-nausea medications. They can also cause blood counts to drop. So especially when we use these drugs intravenously, sometimes your doctor may consider giving growth factors to help the white blood count from dropping down too low. And then we'll jump into the anti-fibril agents. And I know that Conrad from Prothena, Julia from Calum are here, so they'll hopefully be able to speak more about these trials. But bertamimab or NEOD1 is back in a clinical trial now, the FASN AL phase 3 trial. So this is for newly diagnosed AL amyloidosis patients with cardiac involvement. And it's patients with the 2012 staging system, stage 4 disease. It's a soup of numbers and alphabets over here, but these are the criteria that make a patient eligible to go on this trial. And the important thing in this current trial is that it's only for newly diagnosed patients, and they cannot have yet started chemotherapy treatment. So it's so important that in newly diagnosed patients, we are able to get them to a site where these trials are an option. The Calum trials are similar. They are also open in some of the same sites. So it's another option for newly diagnosed patients. There are some subtle differences between the two studies. So while some amyloid patients might be eligible for both FASN and the Calum trials, there are some differences in which a patient might only be eligible for one, but not the other. And I've tried to show those differences on this slide. So with the bertamimab study, it's for the 2012 staging system. So it uses slightly different cutoffs for BNP, NT-proBNP, and troponin, and also takes into account how much free light chain there is in circulation. So what we call as the DFLC, and that number has to be greater than or equal to 180 milligram per liter or 18 milligram per deciliter. Whereas the Calum trials, it's the older staging system, the 2004 staging system, and it's only for stage 3 amyloidosis, but allows 3A and 3B. And again, the cutoffs, as you see listed over here, are a little different than the ones used in this study. The other difference is bertamimab is given every 4 weeks. It's an IV treatment, whereas KIL101 is given bi-weekly, also intravenously. The Calum trial does allow 2 weeks of chemotherapy prior to randomization, whereas with the bertamimab study, prior chemotherapy is not allowed. There are a number of other antifibril therapies that are early in development. And I know Spencer is here from Atralis, and he'll hopefully talk more about these exciting agents, PAR with fusion, as well as these light chain stabilizers. Again, very early in drug development, we heard some data, some preliminary data on 82 at the ISA meeting. Light chain stabilizers are small molecules that can preferentially bind to natively folded light chains, so light chains in the right structure in which they should be, where they don't misfold. And these stabilizers then act as they prevent the protein from unfolding and aggregating into fibrils. So these are the exciting, I think, new drugs that are in the pipeline, and I'm hopeful that in the next near future, these will slowly move into clinical trials and become options for our patients. So with that, I'll stop sharing and I'll hand the podium back to Muriel.
Thank you very much. That was great. You were given this assignment last night and you ran with it. So thank you so much. If we could have Dr. Rosenbaum and Dr. Gertz, if he's back with us. And you made reference, Dr. D'Souza, to a clinical trial that Dr. Rosenbaum had. So since we were actually a couple of minutes ahead of time, so Dr. Rosenbaum, I'll give you 2 minutes to tell us about the clinical trial to which Dr. D'Souza referenced. Okay, you're on mute right now.
Thank you. Yes, thank you, Dr. D'Souza. I wanted to just echo, we did present our preliminary results last month in Heidelberg. And really just the main bullet points are that this trial is uniquely examining patients with very early relapse, meaning very small amounts of their amyloid coming back, which is very unique at this point to studies that are allowing those patients to be enrolled, and also looking specifically at new ways to measure very low amounts of disease, very deep remission, blood tests. And so we're really hoping to have some new information in this kind of trial, which is for patients who've had DARA daratumumab, specifically FastPro, the subcutaneous is given in this trial, but have had exposure to daratumumab in the past with Panelists. And it's going well. We have 4 sites open around the country. It is an investigator-initiated trial. And Boston, Dr. Santrawala, myself at Cornell, Dr. D'Souza, of course, in Wisconsin, and then Dr. Leakey in Stanford. So all 4 sites have this open. So please reach out to one of those sites if it's in an area where you live near. And I'm happy to answer any questions. Please contact me directly if anyone has any further questions about the study.
Thank you so much. And if you have any questions about that study, and you can get a hold of me and I'll get a hold of Dr. Rosenbaum, so don't worry about that. Can we get Dr. Chakraborty on here too, if he's with us, because for answering questions. So there you go. Okay, great. Hello there, welcome. Okay.
Hi, thank you.
Dr. Gertz, our first question refers to dexamethasone, okay? And this is a patient who's 92 years old, okay, with moderate renal involvement. And he's been successfully stabilized on monthly daratumumab, and he gets 8 milligrams a week of dexamethasone and has for 2 years. But the dex is causing sleep disturbance, and he feels that it's the cause of quadriceps weakness. And he wants to know, what about reducing the frequency of the dex or changing to another steroid? And have you successfully cared for patients with daratumumab alone? So this is for all of you. If any of you disagree, but I'll ask Dr. Gertz first, since he brought up dex, and then we can see if there's any discussion on this.
Thigh muscle weakness is clearly a side effect of dexamethasone, so he's probably accurately aware of his body, because it's quite common. I would be quite comfortable 2 years into it to eliminate the dexamethasone completely. No downside of substituting a corticosteroid like prednisone, but after 2 years of treatment with stabilized disease, age 92, I'd be focusing pretty hard at quality of life, and I would just kick out the dexamethasone completely.
Oh, I think he'll be really glad to hear that.
Well, I don't know if everyone agrees, but that's what I would do.
Okay, well, let's see. Does anyone disagree?
Well, I completely agree. We usually stop dexamethasone after 4 to 6 cycles of induction.
Okay, we've just made someone very happy. Okay, on daratumumab question. Okay, for those of us on Dara for the long term, is it safe for us? I've been on it for 2 years now. And there's quite a few other daratumumab questions, but that question comes up frequently. How long? I know we haven't studied daratumumab for that long, but what do we consider safe, or is there a time period on that? Dr. Chakraborty, since you're on the screen, we'll let you answer that first.
So the question is on the long-term toxicities of daratumumab?
Yeah.
So currently, I don't think we have long-term data on daratumumab, at least in AL amyloidosis. So we cannot say much in AL amyloidosis, but in multiple myeloma, we do have a reasonable long-term data on daratumumab. And to my knowledge, so far, there has not been any long-term toxicity that have emerged. It's mostly the infection that is an ongoing side effect of daratumumab that we can see even beyond the first 6 to 8 cycles. But other than the infection risk, we have not really seen any long-term toxicity like second malignancies, for example.
Okay, and Dr. Gertz, well, I guess our go-to for this would be the Andromeda trial, right? And how long has that been running long?
This was for Dr. Gertz.
Dr. Gertz?
So I think that virtually everybody has completed at this point from Andromeda their 24 months. And the original Andromeda plan was 24 months of therapy, and recognizing that the biology of amyloid is very different from the biology of myeloma. I don't think there's really any data out there that suggests that therapy needs to be continued indefinitely. I don't think that we have any good answers about optimal duration, but normally I adhere to the Andromeda design, which means after 24 months, I'm stopping all therapy. Certainly we don't use, I think majority of people don't use therapy, maintenance therapy after standard induction or after transplant. And so my inclination, because the biology of the amyloid producing plasma cells is so different, that the concept of indefinite maintenance therapy, I think, is unproven. And I'm kind of calling it a day at 24 months and monitoring, my policy anyway.
Okay, Dr. Rosenbaum?
I agree completely. We have no data in that. And I think the toxicities are underplayed in terms of infectious toxicities. We're seeing very low humoral response, humoral immune system with ongoing daratumumab, many viral infections, and we don't have data that shows it actually helps. And it is a completely different biology than myeloma. We know that dara works very quickly in our amyloid patients when they have visible disease.
Okay, Dr. D'Souza.
Yeah, I agree. In fact, in a patient who has had a complete response, I might even be inclined, if they're having problems with infections, I might even stop at 1 year. I think there's no magic number with the 2 years. It's what was used in Andromeda study. One could even design a study comparing 1 versus 2 years of treatment. And you know, if we stop it and say a year later, there's need to start again, we can always resume daratumumab again at that point.
Okay, I see Dr. Gertz nodding, so I guess he goes along with that. Dr. Chakraborty?
Yeah, I completely agree. Just similar to what Dr. D'Souza said, we also usually stop at 1 year. We rarely complete like the full 2 years of maintenance at most patients. And if somebody had like a bad pneumonia at 8 months or 9 months, I would usually stop at that point as long as they are in a CR.
Okay, we're bringing up infection here, and we always heard prior to the world of daratumumab that Velcade made one subject to possible infection. So is this a similar, either completely different drugs with different mechanisms of action, but if you're on both of them, Dara, Cyber-D, I guess, does that mean you're at a high risk for infection and should you be on some sort of antibiotic or something? Dr. Gertz?
Well, to tell you the truth, based on data in myeloma, when we induce therapy, I've started putting people on antibiotics for the first 2 cycles of therapy. I get worried, people with, quote, chronic heart disease, chronic kidney disease, which is amyloid, starting chemotherapy. I do worry about a fulminant infection occurring early on. So I don't have indefinite antibiotic preventative therapy, but I'll put them on for the first 2 cycles. I get pretty nervous about the whole thing.
Would that be doxycycline that you put them on?
No, it wouldn't. It would be a fluoroquinolone antibiotic such as levofloxacin. There's data for that in multiple myeloma. There isn't data for that for amyloid, but I think that there is a critical infection risk when you start chemotherapy to patients who have chronic heart failure or chronic kidney problems, and I use it. But I admit it is not proven scientifically.
Okay, Dr. Rosenbaum, anything to add to that?
Not really. I mean, I just want to say one part that hasn't been mentioned, that, I mean, in amyloid, many treatment regimens are personalized. So if you have someone with very high risk, cardiac disease who presented just like the patients we used to give the Velcade maintenance to, and continued that in the highest risk patients, I think you just have to work with your doctor. This does not apply, 100%, but, again, personalized treatment.
Okay, and how long should they be on acyclovir? I know with Velcade, there's a big danger of shingles. Is that compounded with the daratumumab, or is it the same? What's the story there?
I mean, I can answer just anecdotally. You know, we definitely worry about immune deficiency in both Velcade and daratumumab, and there's a role of antibodies in protecting from viral infections as well. And we have seen many patients on daratumumab have shingles outbreaks. So, you know, not only just the Shingrix vaccine, but on top of it, because we can't tell how much someone responds to that, especially if they get it when they're on Dara, is the acyclovir, and it usually has very little toxicity. But so I think that is reasonable to discuss with their physician.
Okay, so Shingrix and acyclovir. Okay.
Yeah, you need to be vaccinated for sure against shingles. And I echo about Dr. Rosenbaum's comment about customization, but that kind of customization only comes with experience. I mean, if you see one patient with amyloid every 4 years, you read what's in a book or a book chapter that one of us has written, and then you would apply that, and you don't get that feel for, I'm going to change the DEX, I'm going to stop the DARA early, I'm going to reduce the bortezomib. That really requires experience, and I just think that's worth emphasizing.
Okay. Okay. Anyone want to add anything to that before we go on? Okay. Okay. What is the current? All right, we'll skip that one. How long does it usually take upon completion of treatment with Darzalex for immunoglobulins to return to their pre-treatment level, Dr. Gertz?
Oh, I don't know. It's long though. I mean, I don't really even try to answer that, because that suppression of plasma cells is long, and we've looked in the blood, and I mean, Darzalex is there 6 to 9 months after you stop it. And so I don't know if my colleagues have a better answer, but for me, that's I don't know, but it's a long time.
All right. Anyone, Dr. D'Souza?
Yeah, it's such a great question. I wish I knew the answer to that. And I have some patients on other antibodies where we have stopped, and a year and a half later, we still don't see any immunoglobulins. So yeah, we don't know.
Anyone else want to add to that?
And especially confounded with after transplant. I mean, it could be, 18, 24 months until someone's immune system completely recovers. So confounded with the comment of, we really don't know much in a maintenance post-transplant or right now with these drugs. Yeah.
Okay, now, Dr. Rosenbaum, you mentioned the fact that you keep them on Dara-Cyber-D for a certain amount of time, then you stop it. You can always go back to it. Okay, what is your experience with someone being off Dara-Cyber-D for a certain amount of time and then going back to it? Do you put them just on Dara? Do you put them on Dara-Cyber? Do you usually, and what is your experience with that?
Oh, I don't, well, I can comment, at least in our study, that's actually why we're doing a study of Dara re-exposure. It has not been actually studied before. We're looking at side effect, toxicities, efficacy, different things there. But I would not typically in a outside of a study in a relapse setting start back Dara-Cyber-D likely, because I think the patients have had all 3 drugs. We don't know of a benefit of that. We do have other, for patients who do not have symptomatic heart failure, we do have IMiDS are very effective in amyloid. We know that. We wish we could use them in everyone. And so they're very good second line drugs. And whether it's a combination regimen of Dara re-exposed with that is what we're studying.
Okay, now the question will be the elephant in the room question, stem cell transplant. Okay. And we heard a lot about that at the International Society of Amyloidosis. Surprisingly, a lot of studies on stem cell transplants. If anyone had thought that wasn't happening anymore, after going to the International Society of Amyloidosis meeting, we found out it's happening a lot. So this person wrote in, is a stem cell transplant absolutely necessary and or always recommended with the new drugs and advances being made with amyloidosis? So Dr. Rosenbaum, you've got the floor here. So what do you think?
I mean, I'll just come out, you know, and say we always value transplant. There has not been a study to say transplant up front is not the standard of care. And even I think some of that comment is coming from now we have in the last few years a lot more data showing patients who were not initially eligible for transplant after induction, you know, even after more substantial induction regimens become eligible, and just the feasibility of that. And so I think, you know, unlike myeloma, I think, you know, we have a lot of opportunities now for upfront transplant or what we would typically have called consolidation after induction. And I think we need more studies for that. But, you know, I do not agree that transplant is delayed in the majority of amyloid patients into relapse setting. We do have no studies that show the benefit of that.
Dr. Gertz, what are your feelings about stem cell transplants? I know you were very pro a few years ago.
I'm still pro, but of course we have more choices now. And what we're currently doing is for patients who are eligible, so there's a big safety assessment that's required, is we'll treat them with DARA VCD or DARA Cyborg. And if they're in the 60% who achieve a complete response, we'll often collect stem cells and observe only. But if they've not achieved a complete response, that's 40% of patients, and they're eligible, we will follow that treatment with transplant. Our goal here is to get people into a complete response. Short of a complete response, we're not comfortable that we really have the amyloid under control. And as a consequence, we think transplant is an important, the technical term is consolidation for patients who fail to achieve very deep responses.
Are you talking about an MRD type response, an MRD negative?
No, but we'd like to see them in a complete response. For some patients, maybe a very good partial response, but anything less than that, we think it's not enough. And for second line then, or for the next step, for us, that would be transplant for those patients that we can do it safely.
Okay, and Dr. D'Souza, where do you stand on stem cell transplants?
Yeah, and I think to follow up on Dr. Gertz's point, the other thing is the durability of complete response. Remember that the Andromeda study results that so far we know, the patients have only had a median follow-up of a year's time. So we don't know, like in that second year or after stopping the second year of daratumumab, what happens to that CR? Is it durable? Whereas with stem cell transplant, we know well what is the durability. Patients who remain in a CR at 1 year after transplant, even 5 years later, quite a few of them still maintain that complete response. So sometimes this just becomes a decision we take after a discussion of the pros and cons of each approach. For some patients needing to come back to the treatment center every month to get daratumumab each month, that might not be something they want to do. In that case, doing a stem cell transplant and then, you know, with the potential of not needing to go on more treatment after that is something that is attractive. On the other hand, transplant does have toxicity. It's going to lower quality of life in that initial 3 to 6 month period. And that is something we have to respect. Transplant-related mortality is also a little higher compared to doing the same transplant in patients with multiple myeloma. So I agree with what was said earlier. I do collect stem cells at around after 3 to 4 cycles of Dara-Cyborg-D. And then we take it from there. If patients choose to stay on Dara-Cyborg-D, they are in a good CR, we can always do the stem cell transplant if we need to at first relapse. On the other hand, if we are seeing toxicities, we are not seeing a deep response, then I think the writing is more on the wall that maybe transplant is the next line that we have to pursue.
Okay, and Dr. Chakraborty, we'll hear from you.
I have little to add over what has been said. The only thing I would say is that for patients who are in a CR with Dara-Cyborg-D, we are doing transplant less and less in those patients. For those who have not achieved the CR and they are otherwise perfectly transplant eligible, we do consider transplant in them. But just given all the new drugs that have come along, for example, in T1114 patients, even if they are not in CR with Dara-Cyborg-D, we give venetoclax and then they achieve a CR. And there is that we think the transplant-related mortality is going to be slightly high, we are not transplanting them at our
Okay,
center.
so it sounds like you're doing fewer transplants, and it sounds like here in the Midwest, we have more happening. And Dr. Rosenbaum's kind of on the fence there a little bit. Okay, that's interesting. Okay, thank you all. We'll be back to you soon. Right now, we're going to hear everything you wanted to know about the kidneys, but we're afraid to ask, from Dr. Nelson Leung from the Mayo Rochester. So Dr. Leung, are you there?
I am, Muriel.
We appreciate your coming today. I know you're taking care of patients and you're kind of squeezing us in.
No problem. So I have slides. Is that okay, or should I go
That's
without?
wonderful. No, that's perfect.
Okay, so I'm going to share my slides. All right. Well, hi, everybody. My name is Nelson Leung. I'm one of the nephrologists at the Mayo Clinic. And today I'm going to be talking to you about renal replacement therapy in amyloidosis. So most of you already know the kidney is one of the primary organs that are involved by amyloidosis. This is a study done by Dr. Gertz and Dr. Kyle many years ago. And it shows that patients, about a third of the patients present with nephrotic syndrome, which is a condition where patient is losing a lot of protein. They get swelling and low albumin and high cholesterol. And about equal number of patients also present with renal insufficiency, and this is when the kidney function begins to deteriorate. And this is really confirmed in a more recent study by one of our colleagues, Dr. Muhtar, looking again at the Mayo Clinic cohort. And again, what Dr. Muhtar found was that approximately 50% of the patients who present with AL amyloidosis have kidney involvement, either by having spillage of protein, nephrotic syndrome, or renal insufficiency. The only organ that was more common in that study was the heart. So as you can see, the trend continued, and kidney involvement remains very prominent in AL amyloidosis patients. Now, unfortunately, kidney disease is one of the ones that doesn't always do well. So in this study by Dr. Gertz back in 2009, what we found was that in the long-term survivor of patients with AL amyloidosis, 45% of these patients actually progress to end-stage kidney disease. This is when the patient requires dialysis or kidney transplantation. Now, this study was done in 2009, so majority of these patients did not receive novel agents such as Velcade. However, a more recent study done by Dr. Wong, and I believe she did this when she was at Boston University. Currently, she is at UCSF. Still, a third of the patients presented or progressed to end-stage kidney disease. And this was done much later, so majority of these patients actually did receive Velcade. And in fact, in her study, 2/3 of the patient actually achieved a VGPR or better of hematologic response. Now, we have tools that help predict who is going to progress to end-stage kidney disease. In fact, there are two kidney staging systems, one by Dr. Palladini and one by Dr. Kastridis. And what they do is that they can separate patients into 3 stages based on their eGFR, which is the estimated glomerular filtration rate, which is the kidney function that we get from the serum creatinine, and the amount of proteinuria. So this is what Dr. Palladini uses. Dr. Kastridis uses pretty much the same thing, except he does it in a ratio. So it's the eGFR over proteinuria ratio. It's not important to go over the details, but what you can see is that patients who have the stage 3 disease in either model are much more likely to progress to end-stage kidney disease, whereas patients who have stage 1, which is the mildest form, very few of them progress to end-stage kidney disease. And both models also have response and progression criteria where these are criteria that we can look at during the course of treatment to determine if a patient is going to either lose kidney function or maintain their kidney function. And the Palladini criteria, if the creatinine starts to go up by more than 25%, or the eGFR goes down by more than 25%, that is considered a progression. And those patients with progression would be more likely to progress to end-stage kidney disease. Vice versa, if a patient has reduction of their proteinuria, these patients are much more likely to have preservation of their kidney function. And one thing that Dr. Palladini showed was definitely patients who have a VGPR or very good partial response in the hematologic response are more likely to preserve their kidney function than those who have less. Now, all of you are very familiar with the Andromeda trial. Dr. Gertz, Dr. De Sosa, and others have talked about this already. And one of the most exciting things about the Andromeda trial is that, as you can see, the addition of daratumumab to Cyborg-D was able to push the VGPR rate all the way up to 82%. This doubled the previous VGPR rate with using Cyborg-D alone. And what that did was that it also doubled the organ response rates. Cardiac response was noted at over 50%. And in fact, one of the earlier reports of the Andromeda trial showed that 83% of the patient actually achieved the kidney response. However, it is still not 100%. And why is that? Well, I think the study from the UK Amyloidosis Center really tells the story. And what this says is that patients with kidney involvement needs to have a greater than 90% reduction in the DFLC. DFLC is the involved free light chain minus the uninvolved free light chain. So this is one way that we says that this is a VGPR. Other way is that the DFLC has to be less than 4 milligrams per deciliter. So again, going back to the study, this study is with patients that have stage 3 renal amyloidosis. And in this study, in order to preserve the kidney function, the patient needs to have a 90% reduction in the DFLC, but not only that, they have to do it within the first 3 months. In patients who achieved the greater than 90% reduction of DFLC, but they did it after 12 months, you see that all of them ended up losing their kidney function and ended up on dialysis. So what this tells us is that, like in the heart, the later the patient is diagnosed, the more advanced the disease is in the kidney, the more reduction of the free light chain is necessary, and it needs to be done in 3 months. It has to be done fast, just like in severe cardiac amyloidosis. So that's why even with regimens like Andromeda with Cyborg-D, some patients may progress to end-stage kidney disease because either not enough of the free light chain is removed or it wasn't done quick enough. Now, I know that there are many in the audience that not all patients in the audience have AL amyloidosis. There are other types of amyloidosis that affect the kidney. And one of the more common ones here in the United States is the ALEC2 amyloidosis. This is a relatively new amyloid that was, excuse me, that was discovered about 15, 20 years ago. And it has very unique characteristics. It tends to affect patients living in certain geographic locations around the world. So the most common populations are those living in Mexico and in the Middle East, as well as in the Punjabi region of India. This amyloid mainly affects the kidney, although it can be found in other organs. The kidney is the only organ that actually get clinically affected. And what the study found was that there are 3 groups of patients. One, that these patients tend to maintain their kidney function. So if the patient was diagnosed with a creatinine of less than 2, which is represented by the green line, they tend to retain their kidney function. Whereas as the creatinine starts to increase, again, more advanced disease, those are the patients that progress to end-stage kidney disease. Other types of amyloidosis are the AA amyloidosis. This is what we used to call secondary amyloidosis because they're typically secondary to infection, inflammation, such as from connective tissue disorders. And there are genetic variants that cause periodic fever syndrome, that cause inflammation without infection. And these patients also develop AA amyloidosis. And once again, you see that in AA amyloidosis, the kidney is the main organ of involvement. And in fact, in this study, the progression to end-stage kidney disease rival those of patients with AL amyloidosis. So again, not all patients that we treat with for amyloidosis can we preserve their kidney function. And so renal replacement therapy is a part of the therapy that we provide to the patients. And renal replacement therapy, the first foremost is dialysis. So how do we choose the type of dialysis for our patients? There are 2 main types of dialysis. There's the hemodialysis and the peritoneal dialysis. And we'll go through these in greater detail. Now, one thing that is required for dialysis is an access. Access is how we get access to either blood or body fluid. And for hemodialysis, there are 3 types of access. There's the fistula, the graft, and the catheter. And in the peritoneal dialysis, there's the peritoneal dialysis catheter. So for hemodialysis, the fistula or graft are devices that we surgically implant into the patient. With the fistula, we use the patient's own vein to connect with the artery so that we can get a large amount of blood. With a graft, if your veins are not good enough, then an artificial material catheter is placed into the vein and artery, and this now becomes the device that we access the blood through. Both of these are considered superior access to the catheter because of the lower infection rate. Fistula, using your own body, is obviously the better form of access than the graft, because this is an artificial device. This still can be infected, although its infection rate is much less than that of the catheter. Now here's the catheter. Typically for dialysis, the catheter is placed into the internal jugular vein, and the catheter actually goes all the way down into the heart, where that's where the blood is pulled from. Now, unfortunately, as I said, the catheter infection rate is much higher than that of the fistula and the graft. And as you can see from this picture, because the end of the catheter sits right in the heart, infection of the catheter actually can lead to infection of the heart, which we call endocarditis. Also, because the catheter is in the bloodstream, any infection that goes on in the catheter is a bloodstream infection. And as you all know, bloodstream infections are quite serious. And that's why, you know, those of you on dialysis, your dialysis unit is probably harassing you about switching to a fistula or graft to get you away from the dialysis catheter. Having said that, there are situations where the graft or fistula may not be feasible, and you may have to be maintained on the catheter. And I have patients that have gone 1 to 2 years with the same catheter without an infection. So if you take care of it properly, you can make the catheter work. But once again, the potential risks are there. So with hemodialysis, there are 2 types. There's what's called in-center hemodialysis. This is one where you go to a center, they hook you up to a machine, and typically you bring a book or you watch TV, or you can even go to sleep. And everything is done for you. When it's done, you leave and you head home. The advantage of in-center hemodialysis is that no training is required. They do everything for you. It's basically like those George Foreman grill, you press it and forget it. However, the disadvantage is that it's a bit of a chore. It's like going to work. There are set hours that you have to be there. And in those of you who live in rural areas, travel time can be long going to the dialysis center. And if you were to travel, you need to have pre-arrangements. So you have to get an appointment with the local dialysis center where you're traveling to prior to leaving. And it's not available in all places. So for example, a lot of people in Minnesota go up to the Boundary Water for vacation. There's no dialysis for about 100 miles from the Boundary Water. So you can't always go to all places in the world. Having said that, there are dialysis cruises that patients can go to, and they cruise just like everyone else. The other dialysis modality is the peritoneal dialysis. And what you need is a catheter that goes into the abdomen. Now, most people are freaked out by this, but this actually gets taped up really nice and neat. And you can put a t-shirt over that and nobody even knows that you have a dialysis catheter. And it's actually much more convenient than most people think. Most peritoneal dialysis are done at night, and it's done by a machine called the Seidler. This machine automatically infuses and drains fluid from your body while you're sleeping. And patients hook up at night, and they're usually done in the morning, and they're free to go. There's another way which is more popular in other countries, which is called continuous ambulatory peritoneal dialysis catheter. This, what people do is that they hang a bag of dialysis fluid, infuse it into belly, and then drain it several hours later. This process takes about 30 minutes, and a patient would have to do this 3-4 times a day. Again, this is more common in other countries, whereas the Seidler is much more common here in the US. But either way, patients are free to go. They're not tied to a dialysis center. And generally, the quality of life is much better for peritoneal dialysis. So the advantages are that it's performed at home. You don't have to go anywhere. You can do it whenever you want. The hours are flexible. If you work nights, you can do dialysis during the day when you sleep. Patients are typically free during their wake hours when they're not in bed. And the ability to travel is much easier. I had one patient who took his gear in the back of his truck and went camping with his wife. So you can definitely do that. Disadvantages, though, is that you have to do it yourself. Nobody comes into your home to do it for you. So you do have to undergo some training. However, the training is not hard. I had one patient who was legally blind, and he set up a camera that goes to his computer and magnified everything, and he was able to do it himself. One disadvantage, though, is that you cannot swim. You cannot swim, at least in ponds or lakes. You can swim in the ocean. You probably shouldn't be in hot tubs either. Other disadvantages, the membranes in the abdomen can wear out over time. So it is not a permanent solution for some people. And you need adequate storage in your home. So these boxes, these fluid comes in big boxes. So you need a place to store them. Interestingly, I had a patient who booked a round the world cruise, and the dialysis company shipped an entire pallet of dialysate, which the cruise ship took onto its storage area. The patients told me that they didn't get on the ship until they saw that the entire pallet of dialysate went into the storage, and then they went on the ship. One other modality is the home hemodialysis. So instead of going to a center, you do the hemodialysis at home. This has a lot of the same advantages as peritoneal dialysis and a lot of the same disadvantages. Now, with the home dialysis, because of the complexity, the patient can't do it him or herself. You need actually an assistant to help take you, put you on and take you off dialysis. You need to have an arrangement to support you with an in-center hemodialysis center to support you for the supplies and also when you travel. And again, you need storage space in your house in order to do the hemodialysis. Now, renal dialysis is only one form of renal replacement therapy. The other form is, of course, kidney transplantation. And at Mayo, we've been doing kidney transplantation on our AL amyloidosis now for over 30 years, almost as long as our kidney transplant program. And over time, we have found ways to make the kidney transplant work quite well. This is just showing you a couple of studies where we have shown that patients who have AL amyloidosis can undergo a kidney transplant either before they had a stem cell transplantation, after they have a stem cell transplantation, or after they have chemotherapy that put them into a hematologic response. And they all do quite well. And our experience has been duplicated by others. This is a study out of Memorial Sloan Kettering showing you again that the kidney allograft survival was quite good in this. The 50% allograft survival was over 10 years, and the patient survival was way over, the median patient survival was way over 10 years. In fact, and this is another study out of the Boston University, again showing very good outcomes both from the kidney standpoint and the patient standpoint. Now, what's most important is that from all of these studies, the patient has to be in a CR, complete response, or a VGPR in order to undergo the kidney transplantation. Patients that have lower hematologic responses generally don't do as well, and the risk of recurrence to the allograft is much higher. This is a update on our Mayo study. This is 60 patients from the Mayo Clinic. And again, we see that VGPR or CR patients do the best, which is represented in the blue line. And in fact, over 70% of the patients still have their kidney allograft after 10 years. Those that have a partial response or less are the ones who do poorly with kidney transplantation. So in order to get to kidney transplantation, if those of you who are exploring that, if your transplant center is not allowing you, one of the reasons may be that your hematologic response is not deep enough. How about other amyloidosis? Well, this is a fibrinogen A amyloidosis experience from the UK Amyloidosis Center. Now, fibrinogen A alpha amyloidosis is a hereditary type of amyloidosis. And unfortunately, the transplant or the amyloidosis reoccur after the transplantation. What Dr. Gilmore and his colleagues found out, though, was that if these patient underwent a combined liver kidney transplant, then the recurrence does not occur. Now, this begs the question whether or not you can do a liver transplant alone if you know early enough that you have the fibrinogen A amyloidosis. And there have been a couple of patients now that have undergone a preemptive liver transplant to try to protect the kidneys from failing. So far, it seems to work. However, this only works if there is very little damage to the kidney. So it means that it has to be caught early and that there's still very good kidney function in that patient to undergo the liver transplant. So with that, I'll take any questions.
Thank you so much. What we're going to do is we're going to hear from Dr. Urey on the cardiac, and then we're going to hit both of you up with questions. We've got quite a few, but because of time, we may ask you to email back some of the responses. So thank you very much, Dr. Leung. And now we will hear from Dr. Urey from UCSD. Are you there?
I am here. Can you hear me okay?
I can.
Thank you for the invite. I'm really excited to share this topic with everyone, AL amyloidosis in the heart. I'm a cardiologist that works closely with colleagues from nephrology, hematology, and a number of other disciplines. This is going to be my focus today, making the diagnosis, heart failure, fluid management, which is the real big challenge for many of the patients that have heart involvement. Some of the electrical complications that we see, such as heart rhythm issues and also the need for devices, lightheaded and dizziness, which is a fairly difficult symptom to manage. And then also I'll discuss advanced therapies and do we even need these advanced therapies? Is improvement possible in the heart? The diagnosis is important. Dr. Leung already alluded to the fact that the heart in some case series is involved in over 50% of the time with those that have AL amyloidosis. And it's important to identify heart involvement because it is closely tied and the leading cause of death in this patient population. Some of the possible clues that I look for or that I advise my colleagues when they suspect that there may be heart involvement are shortness of breath, fatigue, palpitations, or extra heartbeats. And there's a number of studies that we can do that may suggest that amyloid is involved in the heart, such as EKG or electrocardiogram, ultrasound of the heart. And if patients get event monitors to try to understand why they're having symptoms, these wearable event monitors that can last anywhere from about 24 hours to even 3 months, sometimes that may be the initial clue. There's also blood tests that are done fairly frequently if you're diagnosed with amyloid as part of the routine assessment of other organs, which is troponin and BNP, and those can be extremely elevated at times, and those would be very suggestive of amyloid involvement in the heart. Amyloid in the heart, particularly AL, causes those biomarkers or those blood tests to go really, really high, more so than most patients, even with like heart attacks or other conditions. So it's very helpful if you have those tests. The diagnosis, I have some images here of an ultrasound, can often be made with just another organ or another site that's already identified amyloid, such as the fat pad, maybe the kidney. And if you have the characteristic findings on ultrasound and blood tests, you don't need a biopsy of the heart. We don't really need to biopsy every organ that may be involved. Often symptoms and other clues will be sufficient. I also have a picture of an MRI. Many patients may be referred for that. And that may be a little bit better to identify the burden of amyloid in the heart and also follow disease progression more so than echo. But if you don't have the diagnosis made on fat pad or on a kidney biopsy, or the bone marrow doesn't identify amyloid, and in collaboration with the hematologist, we decide we have to find tissue, the heart looks like it's involved, we often will do a heart biopsy. And it's a procedure that's commonly done at a lot of heart transplant centers. We do this, Monday through Friday, a number of cases every day. We access the neck veins, the jugular vein, and pass this bioptome into the heart, and then take samples. And essentially, we'll send it to the pathologist. We work with the Mayo Clinic pathology group. We send over our samples if we identify amyloid, and then they'll dissect it more and tell us if it's AL amyloid or a different type of amyloid. There's two amyloids that can commonly affect the heart. There's other more rare kinds that's very infrequent. And then in collaboration with the hematologist, we start the patient on the appropriate therapies. Now, I've already mentioned that heart failure may be one of the most difficult symptoms to manage, and it really is one that requires constant engagement with the cardiologist and the patient, and also with the hematology group, because as has already been mentioned, sometimes some of the therapies can lead to fluid retention. And just to understand why this happens, as amyloid gets into the heart muscle, the heart eventually starts to stiffen, and over time, the body starts to retain fluid. It sends signals and hormones to the kidney, and you start to accumulate fluid potentially. And that may present as swelling in the legs, fullness of the abdomen, weight gain, or maybe just shortness of breath. Often it may just go somewhat unnoticed, other than the patient may feel more symptoms, but not have very clear signs of fluid overload. We often require diuretics, and these are some of the diuretics that I use. And I want to just highlight that torsemide and bumetanide or Bumex are the ones that I often go to because they're absorbed a little bit better. So while Lasix is the most common, also known as furosemide, diuretic used, we often have to use one of the more potent ones, especially if we see that fluid retention isn't improving much. And that could be even high doses of diuretics. There's other diuretics that may help boost the response, like metolazone. Often that may be considered. With caution, that does have a little bit of more impact on wasting of certain electrolytes. So I don't like to use that much, but I sometimes may use it. And then, as I mentioned, if the patient calls and tells me every time they get their Cyberdy and DARE, particularly the dexamethasone, they retain fluid, then I may give them instructions to increase the diuretics around treatment time, or also discuss with the hematologist about whether that still needs to continue or can they dose reduce it. There is important medications that we use in heart failure, and one of the common, I think, frustrations that patients have is they take meds and they feel worse. And that's because we have heart failure specific medications that are used for other conditions, such as heart attacks with heart failure, that are not safe or may not be well tolerated. So it is important to recognize that the heart failure therapies are often not applicable in cardiac amyloidosis. I want to mention a few of them. Many of these may sound familiar. You may be on some of them or may have taken some of these, but spironolactone is one that we use when the ejection fraction drops or the function of the heart drops. And that's fairly safe in amyloid. I do use this often. I have no major concerns, assuming that the kidney function is stable and that the electrolytes are okay. But I often use this in combination with one of the other diuretics, such as Lasix or torsemide that I mentioned on the prior slide. The ones that have a limited role are things like Entresto, losartan, lisinopril, and often patients may be on these medications for other reasons. but they should not be used specifically for cardiac amyloid. If they're on it for hypertension or high blood pressure, that may still be okay to continue, with the caveat that if the heart function worsens, those medications may not be well tolerated long-term. So I often go over education on medications that may be well tolerated today, but if the heart function deteriorates or if the heart involvement progresses, we may have to scale back on these medications. And then the ones that I really try to avoid, there are certain cases that we may need to use them, are beta blockers, metoprolol and carvedilol being two of the ones that are most commonly used just in general, because they may worsen heart failure and cause lightheadedness and dizziness. There is a really limited role for its use, and I'll mention it on the next slide. But often it's about looking at the medication list, and that's the job of the cardiologist, and make sure that the therapies we're using are not going to exacerbate or worsen the heart symptoms and the heart involvement. This illustration here is from a publication our group had in one of the electrical journals of cardiology, and it really highlights the electrical system and the complications from cardiac amyloidosis. I'm going to go over these: atrial fibrillation and atrial flutter, which is a very common rhythm seen. I also want to discuss a little bit about the risk of stroke, and then also the role of pacemakers and defibrillators. Now, as I mentioned, atrial fibrillation and flutter is a very common rhythm. It's actually common not just in amyloid, it's just common in general. One of the more common rhythms we see of anyone who has any heart disease, whether it's amyloid or something else. And some of the symptoms that you may note if you have it is shortness of breath, palpitations, and heart failure. And that really, heart failure really is something that can happen with atrial fibrillation if the heart rate is fast. So if the heart rate's not fast, we don't necessarily think of an increased risk of heart failure. There's a number of medications that we use, and I think these are important because a fast heart rate in atrial fibrillation over time can cause the heart to get fairly weak. And we know that the heart can improve if we slow the heart rate down. So I'm talking about heart rates at rest of greater than like 110, 120, 130, sometimes even 150. Digoxin, highly debated. And if you type in digoxin and amyloid, you'll see comments that it leads to toxicity in amyloid. You should avoid it. Even in the publication that I highlighted, we put caution on it, mainly because the reviewers that read our paper wanted us to mention that, but it can be used. It's not really one that has to be avoided. It just has to be used with someone who understands amyloid and also digoxin. So I would say that if you're on it, you don't have to stop it, but just be very cautious, and your doctors should know to check levels. I've already mentioned beta blockers such as metoprolol. That slows the heart rate down, and on the prior slide I mentioned should be used cautiously. This may be one of the few cases that I use it in atrial fibrillation or flutter, only with a fast heart rate. So if someone comes in and is diagnosed with atrial fibrillation, the heart rate's in the normal range, I may put an event monitor to see in a 2-week period, is their heart rate going to go fast? If I don't see that, I don't want to use metoprolol. That's not going to be well tolerated. If I do see fast heart rates, I would consider metoprolol, just with important precautions that I would advise the patient. If you feel dizzy, lightheaded, any specific symptoms that would suggest poor tolerance, please call me. These other medications, diltiazem and verapamil, avoid. And that's commonly used for atrial fibrillation, but really poorly tolerated, can actually make the patient feel worse, could be also dangerous in cardiac amyloidosis. And then there's a number of other medications that we can consider antiarrhythmics, trying to restore a normal heart rate and a normal rhythm, such as amiodarone, which is a very commonly used medication. That one is okay to use in amyloid heart disease. They all have side effects that I won't go over all those in detail. I think that's important to discuss with the prescribing cardiologist, but it is okay to use in amyloid. The same thing with dofetilide. That one I like to use often. I think it has a good side effect profile long-term, with the caveat that it does require a hospital admission. It can't be started in the clinic. It does have to be monitored for about 4 to 6 doses, so about 2 to 3 days in the hospital. But that doesn't mean, I don't want to give you the impression that you have to be in a normal heart rhythm. It's used for symptom control, but even staying in atrial fibrillation or having a normal rhythm, as long as the heart rate is not excessively fast, there's no benefit with one strategy versus the other. And that's often a frustration of patients when they tell me, well, I had a medication started to control the rhythm. I was in a normal rhythm for a month, and then I'm back in atrial fibrillation. I often don't necessarily try to achieve a normal rhythm unless they have symptoms. And some patients will have symptoms they can tell when they pop in to this abnormal heart rhythm. I have a picture here of the left atrium, which in amyloid, it gets pretty enlarged. That's one of the hallmark findings on echo. And then as you can see here where that star is located, the left atrial appendage. In atrial fibrillation and flutter, you can form clots really anywhere in the atria, but more commonly in the appendage. It's almost like a little digit. So blood is, in fibrillation and flutter, blood doesn't move well in this enlarged cavity, and clots can form. That's why we have a risk, we have a known risk of stroke. Anyone that has atrial fibrillation or flutter, as long as the bleeding risk is low, should be on a blood thinner. And there's no specific one that's necessary. Warfarin or Coumadin, apixaban, Eliquis, rivaroxaban, those are all reasonable therapies. I also wanted to highlight this device because there is a lot of questions. Can I just get this device and stop blood thinner? This is a device that tries to occlude this little digit, and you can see that there, the device being deployed. It really is not studied in amyloid. And also, as I mentioned, you can form clots in the atria. So I really try to avoid this device because it doesn't change my recommendation for a blood thinner. Maybe it has a role in someone who can't be on blood thinners because of bleeding concerns, but really should be used infrequently because the population study did not have the high risk of clot formation that amyloid patients in the heart have. How about cardioversion, or these procedures that try to shock the heart into normal rhythm? They can be considered, but they're more likely to be associated with long-term failure, meaning you return to this abnormal rhythm. And there's also no clear survival benefit. So it is a riskier procedure in amyloid. One of the risks being associated with it is stroke, without a long-term benefit likely seen. So I often don't recommend it or don't send patients for this procedure unless they're having symptoms and they tell me I feel much better in normal rhythm. They can tell when they go into it, and in that case, we discuss doing that procedure to restore a normal rhythm. And pacemakers and defibrillators are also options. There's very minimal or little data in use of pacemakers and defibrillators. We typically recommend their use as for traditional indications, so not anything specific to AL amyloid. They're often seen, at least pacemakers are often used more commonly in other forms of amyloid of the heart, the TTR version, not AL. So AL patients rarely need a pacemaker, but they may need it. And that's something that you would discuss with your cardiologist. Some of the reasons to get it is if your heart rate is really slow, particularly in atrial fibrillation. That is a common finding, that the heart rate may be fast and over time slow down. There's also things called heart block, where the top chambers of the heart and the bottom chambers don't communicate well. As you can see here in this depiction, there's a pacemaker. There's one, it's a little bit challenging to see, but one of the leads goes to the top chamber of the atria. The second one goes to the ventricle. And if you have poor communication between the top and bottom chambers, you may need a pacemaker. But again, that's also infrequently used. If you're passing out, which is a very challenging symptom, pacemakers don't necessarily help that unless it's associated with an electrical issue of the heart. How about dangerous rhythms such as ventricular tachycardia? These are ventricular fibrillation. These are rhythms that come from the bottom chambers of the heart that can be deadly. In those situations, defibrillators may be considered. Now, the defibrillator, what it does is basically it'll detect an abnormal rhythm, it'll shock the heart back into a normal rhythm, potentially saving the patient's life if it was a deadly rhythm. But because sometimes there's a lot of amyloid in the muscle of the heart, and that's why you're having these rhythms, the device or the defibrillator shocks don't work. They're less effective. So it is important to have a discussion. Once you start seeing ventricular tachycardia or ventricular fibrillation, that's a very poor prognostic indicator. That's a sign of very advanced disease, and that should be taken into consideration before a defibrillator is placed. There's the risk of patients having also what's called sudden cardiac death, which is a very obviously devastating complication that does not go away with a pacemaker defibrillator. So there has been questions about, well, what if I have pretty bad heart involvement? What about just getting a pacemaker defibrillator just to protect myself? It doesn't work, unfortunately, so we don't recommend using those unless there's a true indication for these devices. Lightheaded and dizziness is also a symptom that we see often. And it can be a bit challenging because the first question I always ask, is it likely neurologic? Is it amyloid in the nervous system, including what we call the autonomic nervous system, or is it heart? Some of the clues that may suggest that it's the nervous system is if you also have a lot of bladder infections, difficulty eating, like having the sensation of throwing up quickly after eating. And then your neurologist may do additional testing, and that may help identify if this is from the heart or the nervous system. The most dramatic sign of this or symptom is passing out spells. And if it's seen from moving to sitting to standing, often I recommend conservative measures like making sure that you wear compression stockings, sometimes abdominal binders. If it's seen with exercise, that is a very concerning sign. That should, and I say exercise, not just exercise, but exertion. If you pass out walking a flight of stairs or doing activities, but feel fine at rest, that's very concerning. I often will consider therapies like midodrine, a medication that increases blood pressure and it combats somewhat some of these symptoms. It doesn't necessarily treat the underlying cause, but it can at least help with the symptoms. Fludrocortisone can be used, but I exercise caution with prescribing that if there's a lot of issues of fluid retention and if there's any kidney involvement, then obviously we discuss with the nephrologist. And then a more recent therapy that I've considered and I've used with reasonable success is droxidopa. It is a new medication. It's been around for a number of years. I would say newer in the sense that there's less experience with it, but it does work well. It may be challenging to get. Authorization may be kind of a hurdle that we have to get over. Now, in some of these patients, heart transplant can be considered, and I've included a couple of conclusions from some publications. The top one from Cedars-Sinai, that in carefully selected patients, transplant can be a therapeutic option. Cedars-Sinai is one of the biggest transplant centers in the country. The second one is from Stanford, also showing the same. We're a pretty large transplant center, and I'll show you here at the bottom our survival, which is the red dotted line, 100% for patients with AL amyloidosis. This is over the last 5 years. And the blue line is the comparator group, which is the same time frame, the last 5 years, that were transplanted for other indications, both above 90%, but importantly, the amyloid survival curves are 100, albeit with much lower numbers. Houston Methodist and a number of other centers that I collaborate with, Mayo Scottsdale, Cleveland Clinic, also offer transplant to this patient population with really good short-term and long-term outcomes, with the caveat that they're very highly selected. And I think you already heard before the importance of achieving at least a very good partial response, or ideally a complete response, before transplantation is considered. We also have to look at mutations, the type of therapies the hematologist needed to achieve that. If some of the therapies, for example, some of the IMiDS are necessary to achieve a complete response, then the chance of that patient being a transplant candidate does drop off, as those therapies are associated with a worse prognosis after organ transplant. Some centers, and our center does do multi-organ transplant, but that's very limited. The teaching that every cardiologist that does transplant gets is if your patient has amyloid with more than one organ involvement, and when I say organ involvement, that means with symptoms and signs that that organ is dysfunctional, then that may be a patient that wouldn't be considered for transplant. As I mentioned, our center does multi-organ transplant in those situations after, really a lot of scrutiny and ensuring that they're in a stable place from their hematologic amyloidosis. The indications are heart failure, arrhythmia, as I mentioned, that's a really poor sign, and also syncope, passing out, particularly with exercise. I want to mention LVAD because it is common for patients with heart failure to get these therapies. It's a surgically implanted pump. A number of places have reported its use in amyloid, including the Mayo Clinic. And if it's used, it's often more used in other forms of amyloid, TTR, not necessarily AL, although there are some publications with it. I'll be honest that the data is very minimal, so it's hard to make a strong recommendation for it. Our experience at my center is it's not good, so we don't routinely recommend it. It's really in extreme cases that we considered it because there's very limited success in AL amyloid. So really not part of the standard therapies that would be considered. And lastly, I want to just mention, I'm not going to go over the full organ response from the Andromeda trial, but I do want to at least highlight that recovery is a possibility. And this is a patient of mine in 2020 had an echo, and we don't have to go over all the details, but was diagnosed with AL amyloidosis with significant heart involvement. That was his only organ involved. Some of the findings we'll note is severely dilated left and right atria, and then mild left ventricular hypertrophy. That means mild thickening. The toxicity to the heart is not only because of the amyloid that's infiltrated the heart, but also what's circulating. So our goal was, of course, to get that light chain down and try to decrease the toxicity. And 2 years later, you'll see that the third and fourth conclusion, mildly instead of, which is a change from severely dilated, mildly dilated left and right atria, but the appearance still is consistent with amyloid. We didn't remove the amyloid that was deposited in the heart. But importantly, if you look at I'm gonna ask you to look at the pink line, that's the NT-proBNP. That is a marker that's released when the heart is under stress or strain. When it was diagnosed, it was pretty elevated, 1,500 or so. And actually early on during treatment, it got up to almost 2,500. As you achieved a significant drop, and this is on standard of care, daratumumab and Cardiologist that was mentioned earlier, you'll see that his kappa levels dropped dramatically. And then soon after, his NT-proBNP level started to drop and has been consistent. This is going out to October 2022, so just about a month or so this month. His BNP levels are very much in the normal range now. And what I see in terms of his clinical presentation is he was on bumetanide or Bumex 4 milligrams twice a day, and now he takes it as needed. So a dramatic improvement in his biomarker. Did we change the amyloid in the heart? That's debatable, but at least the toxicity associated with the free light chains has improved significantly. And I think that's evidenced best by the BNP level trend. So take-home points, biopsy is not needed for diagnosis. Fluid management is key for improving quality of life. Heart failure therapies often are avoided and should not be considered as part of standard of care. Blood thinners necessary for atrial fibrillation and flutter. Transplant is a good option as long as you're at a center that understands the nuances and in collaboration with hematology and other organ specialists if there's more than one organ involved. LVAD, very limited role. And then as light chain falls, heart function may improve. I do want to make the comment that in the trials, the organ response with a decrease in the BNP level is about 10 months or so. The best response may not happen at 10 months. It may be years later, but that should hopefully, that gives us some encouraging news when patients start therapy and we start seeing that the BNP drops. And with that, I'll take questions and thank you for your time.
Thank you, Dr. Urey. If I remember 10% of this, if I retain 10% of this, I'll consider there's so much information here. We really appreciate it. We're going to switch a few things around because we've got our insurance Medicare expert coming on. And so we're going to put the break after Monica. But right now, I do have couple of questions I want to ask you and Dr. Leung if he's still with us, okay? And then we're just going to switch things around a little bit. Okay, for the cardiac question, person says, I've been recently diagnosed with stage 4 advanced amyloid of the heart. Is there any research connected with the work of Dr. Esselton, the author of How to Prevent and Reverse Heart Disease, Dr. Greger, or the Whole Foods plant-based approach in connection with improving and curing amyloidosis? Amyloidosis of the heart. Wow.
That's a great question. The research that they both provide is really lifestyle modification for lifestyle-associated heart disease, really cholesterol, diabetes, and atherosclerotic disease, meaning when the arteries of the heart start to accumulate cholesterol and the patient has coronary disease or at risk for like heart attacks, we see that with the plant-based diet, you regress that. To my knowledge, there's no data in amyloid. Of course, we do encourage a healthy lifestyle and lifestyle modification because that does help with heart, and diet, exercise does have a role in heart amyloidosis, but not as a specific therapy to reverse the damage that's done to the heart from the circulating free light chains and from the amyloid that's deposited.
Okay, great. And Dr. Leung, yeah, we've only got time for one question, so I'm going to count on your doctors emailing me lots of responses. Okay. This person says, my husband just started dialysis, end-stage kidney failure. My husband also has AMI in his digestive system. Is he eligible to do the home peritoneal dialysis, or is it not advisable? Can't hear you, Dr. Leung. You're on mute.
So gut amyloidosis by itself is not a contraindication to do peritoneal dialysis. There are some reasons why patients cannot do peritoneal dialysis. One of the reasons is that if they've had a lot of surgeries in the abdomen, that would not be a good candidate. So if this patient has not had any surgery, that would be fine. Another contraindication for peritoneal dialysis is if someone has an aortic aneurysm. That is also a contraindication. But typically, gut amyloidosis, these patients either have diarrhea or constipation, neither of which is an absolute contraindication for doing peritoneal dialysis.
Okay, great, thank you. Okay, well, because we're gonna skip our break, we understand if people have to disappear for a few minutes and come back, we get that. But we do want to get Monica on, and I know that she's got some things that she's committed to. So we're gonna hear all about Medicare and insurance from Monica. Are you there?
Hello, I'm here. Thank you for your flexibility today. Fall Saturdays are always a little bit busy, so I appreciate that very much. So thank you all so much for inviting me to be here to talk a little bit about health insurance, particularly Medicare. My name is Monica Bryant. I am a cancer rights attorney and co-founder and chief operating officer of a nonprofit called Triage Cancer, where we provide education on all the legal and practical things that arise after a serious medical diagnosis like cancer. But I'm here to tell you that most of what we talk about is not cancer specific. We just happen to talk about it through the lens of cancer. So all the resources I'm going to talk about today, even if you don't have a cancer diagnosis, you are more than welcome to avail yourself of them, and they are all free. In this country, there are 3 places where we get health insurance. About 50% of Americans get their health insurance from an employer. The next sort of biggest group, excuse me, gets their insurance through the government, primarily through Medicare and Medicaid. The smallest number of Americans go directly to a health insurance company to get their health insurance. But regardless of where you get your coverage and where you fall on our triangle of coverage, there are some terms that are critical for you to understand. And I will tell you that there have been studies done that show that 96% of Americans do not understand the 4 most basic terms used in health insurance. So I want to make sure that we all are going to leave today being part of that 4% that do understand these terms. So the first, related to costs, is going to be your monthly premium. And that's how much you're going to pay every single month, whether you go to the doctor or not. But then when you actually go to the doctor, you're going to incur some additional costs. Your annual deductible is a fixed dollar amount that you have to pay before your health insurance kicks in. You could have a $500 deductible, you could have a $5,000 deductible. Totally depends on the plan. But once you pay that deductible, then your insurance kicks in, and that insurance is a percentage. And so if you have an 80-20 plan, once you've met your deductible, the insurance covers 80% and you're responsible for 20%. Now, many plans have an additional payment called a co-payment. And again, this is going to be a fixed dollar amount that depends not only on the policy, but it could also depend on the service. So you could have a policy that has a $20 co-payment to see the doctor, or a $30 co-payment to see a specialist, or a $250 co-payment to go to the emergency room. But one of the most valuable things that you all should understand about your specific policy, excuse me, is if it has an out-of-pocket maximum and how much it is. Because the out-of-pocket maximum is, in theory, the most you are going to pay out of pocket for your healthcare for the year. And the way that you get to your out-of-pocket maximum is a math problem. If you have a policy sold through your state health insurance marketplace, then the math problem is we add up everything you pay towards your deductible, everything you pay towards your co-payments, and everything you pay towards your co-insurance for both medical care and prescription drugs. So it's literally everything you're paying out of pocket except those monthly premiums. Now, if you have a plan through an employer or a Medicare plan, it could be a slightly different math problem. So that's why it's important to understand what the math problem is for your plan. Because once you hit that out-of-pocket maximum, the insurance company covers at 100% for the rest of the year. So now that we have those terms under our belt, let's transition into talking specifically about Medicare. As you may know, Medicare is the government program for health insurance benefits for individuals who are over the age of 65 or who have been receiving Social Security disability insurance for 2 or more years, or who have end-stage renal disease or ALS. Those are the only ways to access Medicare. Now, we talk about Medicare as if it's one thing, when in reality, it is multiple things. And it's divided up into different parts, and each part has different benefits. So Part A is hospital insurance. It's going to be when you're inpatient at a hospital. If you've worked and paid into the system, generally speaking, Part A is going to be premium free. But there are some out-of-pocket costs you might incur if you're inpatient for an extended period of time. So Part A is hospital insurance. Part B is medical insurance, and it's where a bulk of your care is going to be covered. Services from doctors, preventative services, home health care, durable medical equipment, IV chemotherapy, all going to be covered under Part B. Even if you've worked and paid into the system, there is a monthly premium for Part B. For most people this year, it's going to be $170 per month. But for individuals with incomes much higher, then their premiums could go up. There's also an annual deductible of $233. And Part B is an 80-20 co-insurance, which means once you've paid your $233 deductible, Medicare kicks in at 80%. You're going to be responsible for 20%. Now, Part B, there's no out-of-pocket maximum. So you're paying 20% all year long. When we talk about Part A and Part B together, that's what's referred to as original Medicare, because it's all that existed when Medicare was signed into law in the 60s. And original Medicare is fee for service, which means you can go to any doctor around the country that accepts Medicare and be seen. So A is hospital insurance, B is medical insurance, D is prescription drug coverage. Part D was signed into law in 2003, so we really haven't had prescription drug coverage in Medicare all that long. And the way that Part D works is they're plans sold by private insurance companies. And so the costs of Part D plans are going to vary from company to company. There is going to be a monthly premium, there's an annual deductible, and it cannot be more than $480 this year. But then the co-insurance is going to vary based on the plan. Now, when Part D was signed into law, it was signed into law with a gap in coverage. That's slowly been closed over time. And so here's what it looks like today. First, the individual has to pay their deductible out of pocket, which can't be more than $480. Once they've paid that, they enter the initial coverage phase. During this period, Medicare picks up 75% of prescription drug costs, and the patient's responsible for 25%. And that continues until someone has paid $7,050 out of pocket. At that point, you enter the catastrophic coverage phase where Medicare picks up 95%, and then the patient's responsible for 5% of their prescription drug costs or a nominal dollar figure, whichever is more. In the context of serious medical diagnoses, it's typically going to be that 5%. So there's some challenges with this. First, you have to pay $7,000 out of pocket before you get to that 5%. And that's a lot of money, particularly when you stop and think about who's on Medicare. It's seniors who often have fixed incomes and individuals with disabilities so severe they cannot work. Where is that $7,000 coming from? The other problem is that 5%. As of right now, that 5% continues for the rest of the year. There is no cap on how much you're going to pay out of pocket. The good news is we have a new law called the Inflation Reduction Act. It was signed into law a few weeks ago, and it does some pretty spectacular things to improve prescription drug coverage. And the first thing it's going to do is, starting in 2024, it's going to eliminate that 5% catastrophic coverage payment. So you're still going to have to pay $7,000-ish. We don't have exact numbers yet because it does change each year. But then after that, that's it. You're done. You don't have to pay that 5% anymore. And that starts in 2024. Then in 2025, it goes one step further, and it's going to cap out-of-pocket drug costs at $2,000. This is significant for our communities. Another thing that's going to happen in 2025 is there's going to be the opportunity for what's called smooth cost sharing. For many people with serious diagnoses, they could get to that $2,000 cap in January. And so instead of having to come up with a $2,000 lump sum in January, they're going to be able to pay it throughout the year in a smoothed way, almost sort of like a payment plan, so that they don't have to come up with that big lump sum. So pretty significant changes. We do unfortunately have to wait one more year until we get them, but at least there's hope on the horizon. I will also tell you, though, that there have been a few elected officials or people who are running for office who say that their first order of business, if they are to become elected officials in this country, is to roll these provisions back. So if this is something that is important to you, I certainly suggest that you talk with your elected officials about their position and maybe share with them why it's so important to you. So A is hospital insurance, B is medical insurance, D is prescription drugs. Someone could potentially have 3 different premiums, cost shares, deductibles. It's a lot. So there is an alternative found in Part C, otherwise known as Medicare Advantage plans. And these are plans sold by private insurance companies, and they're going to bundle all of the services you would get under A and B, and about 90% include prescription drug coverage. The major thing to understand, though, is that these managed care plans, which means there's going to be a network of providers and hospitals and labs. And in order to get coverage, you have to stay within that network. That's kind of the downside. The upside is that with Part C plans, there is an out-of-pocket maximum, which cannot be more than $7,550 for this year. So this is usually where people are like, well, which is better, original Medicare or Medicare Advantage? And my answer is, it depends. If you're someone who never leaves your geographic area and all your providers are covered under the Advantage plan, fantastic. You'll know you have that out-of-pocket maximum. There are lots of people, though, that spend half the year in Florida and half the year in Chicago. And for those people, that's going to be a challenge because it's going to be hard to find a plan with a network across multiple states. So if you are one of those people who moves around during the year or wants to have the freedom of being able to go to other providers, what's the option? You could actually purchase an additional policy called a Medigap plan, sometimes referred to as a supplemental plan. And these are plans, and again, an additional plan that you're going to buy that will cover the out-of-pocket costs associated with Parts A and Parts B. So when someone's trying to figure out their Medicare options, they essentially have 2 lanes they can drive in. Lane 1 is original Medicare, where they pick up Part A for hospital insurance, Part B for medical insurance. Then they decide if they want prescription drug coverage, and if so, they pick up a standalone Part D plan. Then they decide, well, do I want to protect myself from those potential out-of-pocket costs for A and B? If the answer is yes, they purchase an additional policy called a Medigap plan. That's lane one, and lane one, you can go to any provider around the country. Lane two is the Medicare Advantage plan. This is a single policy you're going to purchase that's going to bundle all of the services you get under Parts A and Parts B. And if you pick a plan that doesn't include prescription drug coverage, then you can pick up a standalone Part D plan. But that's where your options in lane two end. And the reason for that is because lane two comes with the out-of-pocket maximum. So I thought it was very opportune for me to get to talk to you about Medicare today, because we are currently in Medicare's open enrollment period. And this is the opportunity where you can actually drive back and forth between those two lanes. So if you're in a situation where you have an Advantage plan and maybe you can't see the doctors you want to see, maybe now's the time to drive back over into the original Medicare. For those of you not on Medicare, I also want to mention that we are about to enter the open enrollment period for the state health insurance marketplaces, and we have tons of information on our website about that. I also would be remiss if I didn't share that things don't just change during open enrollment. And so if you have a change in your life or a loss in coverage, like maybe you're leaving your job, there are special enrollment periods into each type of insurance. Now, it's great that we have these options, but how do we decide what lane we're going to drive in? I'm going to walk you through a quick example, and to make the math work, we had to make some assumptions. And so this is an individual who's going to need IV chemotherapy for 1 year, and the estimated cost is $10,000 a month. So with original Medicare, we take the monthly premium and we multiply it by 12, because that's how much we're going to pay for Part B premiums. They're going to have to pay their deductible, which is $233. And then remember, Part B is an 80-20 plan. So 20% of $10,000 is going to be $24,000 for the year. So when we add all of that up, the total costs to have Part B and to pay for the chemotherapy is going to be $26,274, which is a lot. So let's look at the exact same facts with a Medicare Advantage plan. With Advantage plans, you're going to pay at least your Part B monthly premium. So that's the same. We assumed this Advantage plan does not have an additional premium on top of the Part B premium. And then it's the same co-insurance, except that here we have that out-of-pocket maximum of $7,550. So the total for under Medicare Advantage is going to be $9,591. But we can actually go one step better. Here we have original Medicare with a Medigap Plan G. And we've assumed that Plan G, the national average right now for a Plan G, is $300 a month. So you still pay your Part B premium, you still pay the Part B deductible, but then that 20% co-insurance is picked up by the Plan G. You also have to pay your Plan G monthly premium of $300 for the year. And when we add that up, we get to $5,874. So I know that's quick, but the illustration here is really just to show you that in order to figure out which is the best lane for you to drive in, you have to do this math. And we do have resources at triagecancer.org. We have a Medicare resource hub where we have an archived 90-minute webinar all about health, Medicare. We also have one all about private and employer-sponsored health insurance that you can take a look at. And on that resource hub, you'll find a worksheet that you can print out. And on this worksheet, it actually walks you through how to do the math for your situation and the plans that you are considering. So I strongly suggest, even if you are in a situation where you're like, I love my current plan, I don't want to make any changes, it may be worth spending 20, 30 minutes walking through your other options just to double check that what you choose is still the right option for you moving forward. Now, the good news is we have lots of options, and there are new things coming down the road in the next couple of years. The bad news is, even if you have a great plan, you may face a denial. And what we want you all to know is that you don't have to take no for an answer as a consumer. There is an opportunity to appeal. And about 40 to 60% of the time when people appeal denials of coverage, it gets decided in favor of the patient. So if you get a denial, please avail yourself of the appeals process. We have tools on our website broken down by the different type of insurance on how to appeal. But we also know that many people are not appealing. So just in the marketplace, 99.9% of the claims that were denied were never appealed. So when we talk about how to improve financial health, this is a major piece of the puzzle. So I really appreciate the opportunity to be here and talk to you a little bit about Medicare and insurance and the resources that we have. Again, please don't be turned off by the name of the organization. All of the resources are going to be useful for you as well. And I also want to share that if you have specific questions that we don't get to today or that come up later, you can fill out a form on our website and make an appointment with one of our staff attorneys to walk through your various options, and we will give you next steps to take, because sometimes I know you may not have questions right now, but things may come up later. So Muriel, thank you again so much for inviting me to join you today.
Well, thank you. And if you could repeat it, I mean, not all of us are going to be lucky enough to move next door to you, which we all would like to do. So since we can't do that, if we have a question for Monica to answer for us privately, what is that contact information again?
The best way to do it is go to triagecancer.org/gethelp. There's a quick form to fill out, and then just keep an eye on your email. There'll be a link. You'll get an email back with a link where you can schedule a call with one of us.
Great. And I do have a couple of questions that I'm going to be emailing you because we won't have time to do Q&A with you today. I'm backed up, but that's a personal problem.
No problem. Thank you for being flexible with your break. I hope you all have a lovely rest of the day.
Thank you so much, Monica. Take care. And before we take our break, everyone, I want to let you know that after the break, we'll be hearing from our anti-fibril people that suck out the amyloid from the organs. So I know you're all going to want to hear from Atralis and Prothena and Alexion AstraZeneca, which is the new name replacing Calum. And also we're going to hear from Dr. Chakraborty about an exciting new venetoclax trial as well. So we're going to make that break 5 minutes, but if you want to take longer, it's okay. And we'll see you all in 5 minutes. Okay, now we're going to hear from Dr. Chakraborty at Columbia about a new venetoclax trial. And this is important for many reasons, but for one reason I know is that insurance companies can give you a hard time paying for venetoclax. So this is, clinical trials are one great way of getting a drug for free. So Dr. Chakraborty, take it away.
Sounds good. Thanks, Muriel. I'll share my screen. Okay, all right. Hello, everybody. So I'm Raj Chakraborty from Columbia. So we have, I wanted to talk about this trial, this clinical trial that we just opened at Columbia and should be open at some other sites over the next, hopefully 4 to 6 months. So this is a phase 1/2 trial of venetoclax in relapsed refractory T1114 systemic AL amyloidosis. So just quickly, venetoclax is a very promising drug in AL amyloidosis, especially those who harbor this cytogenetic abnormality called as T1114 or translocation 1114. And it's important to know that about 50% of patients with AL amyloidosis, they will have T1114 as opposed to only about 15 to 20% of patients with multiple myeloma. So it's usually enriched in patients with AL amyloidosis. And as you can see in this screen, this was a study that was a multi-center study which was led by Columbia. And as you can see, the response rate with venetoclax-based regimens was really high, about 78% VGPR and CR rate in patients with T1114. You can see the figure C, whereas in patients who did not have T1114, it was only 30%. So it's kind of a precision medicine and works really well in T1114 patients. So this is the trial that has opened at Columbia and should be opening in some other centers shortly. So it's a phase 1 and randomized phase 2 trial. Initially, we will be doing the phase 1 part of the trial, which will accrue a maximum of 15 patients. And then after that, once we identify the maximal tolerated dose or recommended phase 2 dose from phase 1 part of the trial, then we will go on to the phase 2, which would be a randomized trial where 19 patients will be randomized to venetoclax plus dexamethasone, and 19 patients will be randomized to investigator's choice. And the investigators will have the option to choose from one of these 4 options, which would include pomalidomide, daratumumab, bendamustine, or ixazomib, all of which are routinely used second or third line treatments in patients with AL amyloidosis. So to be eligible for this trial, patients will need to have a biopsy-proven systemic AL amyloidosis at any time point since their diagnosis. They must have T1114 on FISH assay. They must have received at least 1 prior line of therapy containing daratumumab. So for example, if somebody received 2 cycles of Cara and are not having an optimal response, they would be eligible for this trial. So at least 1 prior line of therapy containing daratumumab. If somebody has only received, for example, Cybody, before Cybody came along and now they're relapsing, they would not be eligible for this trial. Then for eligibility, the DFLC, or the difference between involved and uninvolved free light chain, has to be more than 2 milligrams per deciliter or more than 20 milligrams per liter. So the total treatment duration would be 6 cycles. So the trial will pay for venetoclax for a total of 6 cycles. And even for the phase 1 part of the study, the minimum dose will be 200 milligram, which at least in our experience have shown good responses in patients with AL amyloidosis. So the chances that patients will be receiving a suboptimal dose is very low. So these are the sites which, so currently it just opened for accrual at Columbia actually earlier this week. And it will open at Boston University, will be led there by Dr. Sanchorawala. At Mayo Clinic, Rochester, will be led by Dr. Prashant Kapoor there. At Cleveland Clinic, Dr. Jason Valent. At UAB Birmingham, the PI will be Dr. Susan Ball. And Dr. Anita D'Souza, who is here, she will be leading it at MCW Milwaukee. So hopefully all of these sites will open, I would imagine, around March or April 2023, depending on the bureaucratic processes and the budget and the contract. But if you are close to one of these centers, you could certainly reach out to them. And in the meantime, it's open at Columbia. So if any of you think that you may be eligible or need venetoclax or your insurance is not covering, feel free to reach out to me directly. And it's an oral treatment. That's also important to know. There is very less visits that is required to the treating center. So with that, I would like to end, and I'm happy to take any questions.
Thank you very much. I'm right now we're limited for time, so I don't think we're going to be able to ask any questions right now. But thank you so much. Stick around. We might have time at the end. Okay.
Sounds good.
Okay. Thank you. And right now, all of the treatments that we've been talking about, including the venetoclax, they go to stopping the factory that makes amyloid. Okay. But what about the amyloid that's already attacked your heart or your kidneys or whatever, and have damaged the organs? How do we vacuum those out? And those are the treatments that we're going to hear about now that are in clinical trials. Okay. And first we're going to hear from the newest kid on the block with the newest clinical trial for that. And that is Spencer Guthrie from Atralis. So Spencer, take it away.
And thank you very much, Muriel. It's nice to see familiar faces, and it's always great to be able to present to patients. So let me just pull up my screen here.
Perfect.
Sorry. So a little bit about Atralis. We are a relatively new company. We've been around, founded by myself and Dr. Jonathan Weill from University of Tennessee about 2.5 years ago. I think a unique part of our company is we're completely focused on systemic amyloid diseases. And certainly our goal in that is to improve the lives of patients. As Muriel discussed, and some of these have been discussed before, current approved therapies are really focused on suppressing the precursor protein. Sorry, my daughter just walked in. Suppressing the precursor protein. And we are focused on really the amyloid fibrils, so removing the amyloid fibrils that are already deposited in the organs. So we have a number of things that we're studying. We've been developing a pipeline of therapeutics for systemic amyloidosis, and they're in various stages. AT02, which I'll talk about a little bit more, is the furthest along, but we are looking at 4 different types of therapeutics that would potentially remove amyloid. And we're working on diagnostics as well. AT01 has completed phase 2, and this is an imaging agent that I think many of you are familiar with as Dr. Wall's imaging agent. So this was discovered and originally developed at University of Tennessee, and we're continuing that work. So how does this anti-amyloid work? So on the left, you see these are representative of the amyloid fibrils, and the therapeutics we have are really focused on binding directly to the fibrils. So we use components on our therapeutics that are attracted to some similarities on amyloid fibrils. So one unique aspect of this is, we call this pan-amyloid removal, is that we're recognizing components on all types of amyloid fibrils. So these are not specific to AL or ATTR or AA or other. These molecules bind to all types of fibrils. And then there is what's called an FC portion, part of an antibody that triggers the immune system. So basically says to the immune system, hey, there's something here that shouldn't be here, and triggers these large cells called macrophages that come in and can eat the amyloid. So our lead therapeutic is AT02, and this is an antibody structure. And what is unique about this is we have 2 peptides that are infused, that are genetically fused onto the antibody, and these are what drives the attraction and the binding to the amyloid. Just a little bit, I think it was mentioned before, we presented some data, Dr. D'Souza mentioned, at International Society of Amyloidosis on the preclinical profile. So I think, from a preclinical perspective, we've, proven that this binds to really diverse types of amyloid with really high potency. We've tested this in a few animal models. We've been able to show really expedited clearance of human amyloid in an AL mouse model. Because this binds to multiple type of amyloid, we can use multiple different type models. So we've also been able to show this reduction of amyloid in an AA mouse model. And we've completed all the animal toxicology studies and have seen no adverse effects in those studies. Sorry, my daughter's coming in the room. Sorry about that. So this has started clinical development just recently. We have an ongoing single ascending dose study. It's a dose escalation study where you start very low and get up to a dose that may be therapeutically active, or you stop at a dose before you get to something that's not safe or tolerated. And the study is enrolling healthy volunteers and patients with systemic amyloidosis to really look at safety. So it's the first study in humans to look at safety, and also the pharmaceutical properties of the product. So how long it stays in your body, et cetera. Now, this study is ongoing in Australia. There's reasons for that. They have a kind of special access for phase 1 studies. So it was really easier and faster way to get our product going to do the first study in Australia. But we are currently planning a phase 2 efficacy safety study. Assuming all goes well with that study, we expect to start a larger study in the US in the second half of next year. On the imaging agent, so many of you may be familiar with this. Again, this is the one that's been developed by Jonathan Weill. And so this is a PET-CT imaging agent. It uses that same peptide that's in the therapeutic that binds to amyloid. Some of the advantages, it works for all types of amyloid. It's quantitative as PET-CT. And, it may in the future alleviate the need for biopsies in certain patients. It also helps us with our therapeutic development, and really the goals are to get patients diagnosed faster and to improve the diagnostic accuracy. Just to share some of what the pictures look like, this is what the agent is injected into the patients, and then there's a PET CT scan. And in healthy subjects, there's some what's called free radioiodide, because it's an iodide-based product that is in the stomach and the bladder. But this is what a healthy subject looks like. There is no amyloid here. And this is an AL amyloid patient. And so you can see this really bright intensity of the liver, the spleen. This is the heart. And you can see a little bit closer on the right. So you see the left ventricle, which is where amyloid is known to be, but there's also some amyloid here in the right ventricle. And we see amyloid is pretty typical with AL amyloid patients, really kind of diverse array of amyloid in multiple organs. And again, I know we've talked a lot about the kidney today. This is representative of uptake in the kidney. And just to talk about a little bit about that is every AL amyloidosis patient is quite different, from all aspects. But when you look at imaging, it really does stand out. And so these are not all the same patients, but it's just to show sort of a diversity in things that you can see with this imaging agent. The spleen and kidneys are really well lit up here. I think this is the former scan that we showed. There's some patients who have amyloid in their lungs, pancreas, lymph nodes. We've seen some in the bone lesions in patients who have myeloma as well as AL amyloid combined. And now it's been shown that, it's this possibility to use this to detect change in treatment. So this is an example of a patient who was scanned and then was on daratumumab for 2 years, went into a VGPR, and we were able to scan them again and see that there were noticeable changes. So the liver and spleen, it's kind of, you can see a little bit here. So this is the darker means more amyloid, the lighter means less amyloid. This is on the top right, how it's quantified. So you see a pretty significant reduction in liver and spleen amyloid. And what was sort of gratifying to see is that really corresponded well with both the change in the serum free light chains. So as the light chains went down, and serum alk-phos, which is an alkaline phosphatase, is used to measure, sort of a clinical change or a hepatic response for the disease. So to see that along with the change in amyloid, I think was very helpful. And so we're looking further into ways to develop this agent, not only as a diagnostic, but for monitoring disease. And what do we have ongoing? So I've talked at some of these meetings in the past about we did a trial called a repeatability trial, which is basically to see if you do the image twice in a row, do you get the same results? And this is still ongoing. It was done in Northern California, but it is fully enrolled. And many thanks to many of you and Muriel for helping to do that. Dr. Dorbala at Brigham and Women's Hospital has a study going on in AL and ATTR patients, which is still accepting AL patients. Dr. Morie in Portland at OHSU is just starting a study, I think, within the next few weeks, which will also be open to AL and ATTR patients. And Dr. Wall at University of Tennessee is bringing back patients who were originally scanned for a follow-up scan as part of a new study. In addition, we're looking at a sort of a different version of this. So this version, AT01, is using PET CT and a ligand called iodine 124. And so we're testing a different version, which would use SPECT imaging. So similar to the way PYP scans are done, where this peptide is radio labeled with technetium and could be looked at through SPECT scanning. And so that study, again, using the same peptide, because it's using the same peptide, we would expect to see this work in multiple types of amyloid patients, probably in second quarter, mid next year. Another study will be starting at University of Tennessee. And that's it before Muriel cuts me off. Thank you very much for your time.
we don't have a hook, a long distance hook where we can pull you off the stage or anything, but no, really, we wouldn't want to. It's very interesting. Thank you. Hang around. We'll do some Q&A at the end.
Sure,
Okay.
sure, yeah.
Thank you, Spencer. And I want to thank so much to our panelists. As usual, we've gone, behind, and that's my poor judgment. I'm sorry, folks, but there's so much to cram in there, and we don't want to miss out on anything. So we want to thank our panelists very much, our presenters and our attendees. Please don't forget to fill out the survey when you leave. Remember, we're always a phone call or an email away, day or night, but we prefer days, just so you know. Don't forget the survey and stay safe. Thank you, everyone.
Thank you. Take care.
Thank you.